Now moving on to our first section, that is the Colles fracture, which is very common fracture around the distal radius. We will be briefly going through its mechanism of injury, pathological anatomy, clinical features, what are the imaging and x-rays which are done, and what is its treatment. Now coming to the Colles fracture, there are three different types of fractures which usually occur especially around the wrist. One is the Colles, other is the split, and one is the Barton fracture. Barton fracture is, we call it a Barton when it has an interarticular extension. Now the type of fracture depends upon different factors. One is the age of the patient, whether it's a young male or female, or it's an old osteoporotic female, especially who has weak bones. Transfer of energy, was it a simple fall? It could be a low energy fall, or it could be even high energy trauma as well. And the mechanism of injury, was it a fall on the outstretched hand with the forearm pronated and wrist extended, or was it a fall on the back of the hand when the forearm was supinated and the wrist was flexed? Now that determines whether it would be a Colles fracture, or a Smith fracture, would it be an interarticular extension with a volar or dorsal Barton as well or not. And above all, the bone quality, whether the bone quality is good, or it's an osteoporotic female who has weak bones already, even a minor trauma can result in a fracture. So what is Colles fracture? It's a transverse fracture of the distal radius just above the wrist joint with the dorsal displacement of the distal fragment. This is very important to know, that the distal fragment, when goes dorsally, it called as Colles fracture. When it goes volarly, it is called as Smith fracture. The most common of all the fractures, especially in the case of the older people, it has a high incidence related to the onset of postmenopausal osteoporosis. So especially the old age females who are postmenopausal with osteoporotic tendencies usually present to ER with the history of fall on the outstretched hand resulting in a Colles fracture. An older woman who gives history of falling on her outstretched hand. This is a very common mechanism of injury or pathophysiology, especially in the case of Colles fracture. Now coming to this, what actually happens is that the force is applied on the length of the arm with the wrist in extension. As I told you, it's fall on the outstretched hand. The forearm is pronated, the patient is falling with the wrist in extension. So the axial loading is actually occurring on the distal radius and then is transferred towards the elbow. The bone fractures at the corticocondylar junction, that is at this level. Usually these Colles fractures are always extra-articular. Rarely they are intra-articular. The distal fragment collapses into extension. Why? Because the wrist was in extension at the time of injury, resulting in a dorsal displacement of the distal fragment. Radial tilt and shortening occurs in most of the cases. Now coming to the clinical features, what happens is the common fracture pattern is by the dinner fork deformity. If you see this view on the lateral side, you can appreciate the distal fragment is gone dorsally with the proximal fragment going volarly and resulting in dinner fork deformity. And if you see it on the AP view, there is not only a dinner fork deformity, you can appreciate that there is an increased radial tilt as well. So that is something which is very common. The distal fragment is gone dorsally with radially tilting of the distal fragment as well. There's usually, as it is gone dorsally, so there's a prominence of the wrist, depression in the front, and usually the less deformity results in a local tenderness and pain on the wrist movement. Sometimes no obvious deformity is not present. History of a fall on outstretched hand is there. It may be due to the decreased there's low energy trauma, and this may have resulted in a very little displacement of the distal fragment. Now coming to the imaging, the first and foremost is always to get an X-rays of the wrist, AP and lateral view. Sometimes oblique view may be needed, but one thing we need to remember is when we are talking about the wrist, we need to make it sure that we get the X-rays of the radius and ulna along with the elbow joint as well, because the rule is one joint above and one joint below. And if you see it on the X-rays on the wrist, sometimes you see this kind of fracture. If you see this, there is a fracture which is extra-articular along with the radial styloid fracture. And if you see the displacement, this is not massive displacement. The distal fragment is slightly displaced dorsally which could be, in this case, the patient may not have any internal pocket deformity, but there will be definite tenderness, swelling, and decreased range of motion and painful range of motion. Ulnar steroid process, as I told you, is often broken and has to be remembered as well. Radial fragment is sometimes impacted into the radial and backward tilt. If you see over here, if you see the normal anatomy of the distal radius is such that it's, instead of going dorsally, it goes into an 11 degree into volar tilt. So there is 11 degree of volar tilt in normally of the distal radius, but instead of this normal tilt, the distal fragment is actually dorsally tilted. There may be intra-articular fractures, although Colles is rarely intra-articular, most of the time is extra-articular. If you're still not sure about it, it's a subtle injury and you're not sure about it, you can always go for a CT just to see, especially in the case of children when you're not sure whether there is a fracture present or not. Now coming to the treatment. With the Colles, the most common treatment is the close reduction, which could be done under Bayer's block, could be done under hematoma block, or could be done under GA, and then to just apply a simple plaster. Other options, if it could have been an open fracture, we can go for external fixation, just until unless it's highly radially impacted fracture. Even in the close fracture, we sometimes have to go for a distraction fixator. Other options could be a fixation with the K-wire. Sometimes they are done, but until unless we expect that there is an unstable variety of the fracture and eventually get displaced, then probably the going for close reduction and tunnel fixation with K-wires is a good option. Usually volar locking plate is not done, but that is one of the options in which open reduction and tunnel fixation can be done, so that there is anatomic reduction of the distal radius fracture, because later on radioulnar impingement, radiocarpal impingement or radial arthritis could be very damaging, especially as the wrist is one of the very important joints of the body. In this section, we have briefly gone through what are the pathophysiology of the Colles fracture. The most common mechanism is usually elderly lady who's postmenopausal with element of osteoporosis, complains of a low energy fall of the outstretched hand in such a way that forearm is pronated with wrist is extended, producing a dinner fork deformity due to the dorsal displacement of the distal radius. The most commonly it is reduced under GA or hematoma block or a Bayer block by close reduction, and a plaster can be applied, which is the most commonly treated method for the Colles fracture. Other options could include K-wires, a volar locking plate, or even an external fixator, but usually rarely done for the Colles fracture. Thank you very much. Keep watching sqadia.com.